أسيوط يا قلب الصعيد يا حتة مننا. أسيوط يا قلب الصعيد عاشقينك كلنا. أسيوط يا قلب الصعيد يا حتة مننا. أسيوط يا قلب الصعيد عاشقينك كلنا. مهما نجيب ونسافر لازم نرجع في الآخر، في الأول والآخر انت قلبنا. مهما نجيب ونسافر لازم نرجع في الآخر، في الأول والآخر انت قلبنا. أسيوط يا قلب الصعيد يا حتة مننا. أسيوط يا قلب الصعيد عاشقينك كلنا. أسيوط
اسأل عنها ولادها اسأل حافظ شعرين.
اسأل عنها ولادها اسأل محمود حسن اسماعيل.
اسأل عنها ولادها اسأل حافظ شعرين.
اسأل عنها ولادها اسأل محمود حسن اسماعيل.
يا ليلة السيوف لطف المنفضوطي
وجمال عبد الناصر اللي السهراج الوراجي.
أسيوط يا قلب الصعيد يا حتة مننا. أسيوط يا قلب الصعيد عاشقينك كلنا. أسيوط
قول سيدنا الفرغد اللي الكل بيجي ليه.
الدير المحرق اللي الدنيا بتسمع بيه. قول سيدنا الفرغل اللي الكل بيجي ليه.
الدير المحرق اللي الدنيا بتسمع بيه. وقناطر تملى العين 111 عين.
جمعت أسيوط العلمة سهلة الدنيا بتعرف بيه.
أسيوط يا قلب الصعيد يا حتة مننا. أسيوط يا قلب الصعيد عاشقينك كلنا. أسيوط
لفينا شوارع اللي جمالها رائع مش شوية. من شارع الهلالي للني مثل الجمهورية. من جامعة شركة أوزة من يسري للمحطة. من حمرة للزهراء من شارع البحر للولدية.
أسيوط يا قلب الصعيد يا حتة مننا. أسيوط يا قلب الصعيد عاشقينك كلنا. أسيوط
عشقينك كل حدودك من القطر يا البيروت. أبو تيجي الغنايم صدفة الفتح ومنفاروت. عشقينك كل حدودك من القطر يا البيروت. أبو تيجي الغنايم صدفة الفتح ومنفاروت.
مركز حدود ثروة عمرنا ما هننسى واحد.
أبنوب والبداري والساحل مركز الطيور.
أسيوط يا قلب الصعيد يا حتة مننا. أسيوط يا قلب الصعيد عاشقينك كلنا. أسيوط أسيوط يا قلب الصعيد يا حتة مننا. أسيوط يا قلب الصعيد عاشقينك كلنا. أسيوط يا قلب الصعيد يا حتة مننا. أسيوط يا قلب الصعيد عاشقينك كلنا. مهما نجيب ونسافر لازم نرجع في الآخر، في الأول والآخر انت قلبنا. مهما نجيب ونسافر لازم نرجع في الآخر، في الأول والآخر انت قلبنا. أسيوط
اسأل عنها ولادها، اسأل حافظ شعر النيل.
اسأل عنها ولادها، اسأل محمود حسن اسماعيل.
اسأل عنها ولادها، اسأل حافظ شعر النيل.
اسأل عنها ولادها، اسأل محمود حسن اسماعيل.
جلال الدين السيوط، لطف المنفلوطي،
وجمال عبد الناصر اللي في شهراجل وراجل.
أسيوط يا قلب الصعيد يا حتة مننا. أسيوط يا قلب الصعيد عارفينك كلنا. أسيوط
مولد سيدنا الفرغد اللي الكل بيجي ليه.
الدير المحرق اللي الدنيا بتسمع بيه. مولد سيدنا الفرغل اللي الكل بيجي ليه.
الدير المحرق اللي الدنيا بتسمع بيه، وقناطر تملى العين مية.
Really great pleasure and honor to be here with you tonight. I'd like to thank the organizing committee, my very dear friend, for giving me the privilege to be here with you tonight. It's really a pleasure and an honor to be here with you. I'm very impressed with Asiyut. It's my first time in Asiyut city. In my imagination, that was kind of small, basic town. I'm really impressed. I'm going to deliver the same impression when I go back home. Tonight, I'm supposed to talk about the diagnostic strategy for the screening and confirmation of the pulmonary hypertension. Now, before I start, I'd just like to mention something, because when Professor Mahfouz called me, he said, we want you to give a talk because you are the expert in the field. And actually, I was feeling very thrilled. Nobody called me expert in the past, so this was the first time people called me expert. So I thought this is a great thing that I thought about. So I decided to go ahead and look in the dictionary about what expert means. And the term to be expert in the dictionary means a man who's top thinker, because he thinks that he knows everything. So he's actually an empty-minded, basically person. So I thought, this cannot be true. I'm sure that Professor Mahfouz would like me more than this to call me empty-minded, basically person. So I looked at different dictionaries, and I found something interesting to say that expert is somebody who is 1,000 miles away from his house. He's having no social life, no family life, very boring person. Just show you some slides. So the message here, don't feel very kind of thrilled with to call you expert, but expert might not be a very good thing. Now, in the field of pulmonary hypertension, just a couple of slides about the pathophysiology of the disease. It's at the moment we believe that pulmonary hypertension is a combination of two main mechanisms. It's basically a mechanism when people they have some vascular tone, increasing vascular tone, but that's only the early process that's usually followed by remodeling and stiffness of the vascularity itself. That leads to a condition called the pulmonary vascular disease that leads to the rise in the pulmonary vascular resistance, which is actually the hallmark of the pulmonary hypertension, and that leads to the further real complication. If you look at what happens in pulmonary hypertension, there is proliferation of all layers of the pulmonary vessels. That include the epithelium, media, and intima. And that leads eventually to the occlusion of the pulmonary artery completely. Further on, there will be some recanalization of these obstructed arteries, hence the name ipsiform lesion, which is supposed to be the very characteristic for the pulmonary hypertension. What we believe at the moment is happening that initially there is the initial step is the progressive rise in the pulmonary vascular resistance, and that can go really in parallel with the increase in the symptoms. However, the pulmonary artery pressure goes initially with it up there, it begins increasing as long as the cardiac output is maintained. Now, once the cardiac output starts falling down, you can see that the pulmonary pressure start falling down as well. So when we check my echocardiography, and somebody come and tell me that the echo is better because the PA pressure was 100, and now the PA pressure is now 70, that might not be a good idea. That might not be good news for the patient, because that simply might mean now that the cardiac output is really dropping significantly and mortality becomes extremely high. If you look at those patients who have the combination of decreased cardiac output and right heart failure, really the mortality is drastic in those kind of patients. And if you look at the median survival for the pulmonary hypertension patient, it's 2.8 years. Only 2.8 years, the average survival of those patients. Now let me remind you that if you look at the survival for the worst cancer we know, stage 4 lung cancer, the average survival is about 5 months. If you look at a patient who has very advanced PH, those are already in NYHA class 4, the survival is basically 6 months, which is very close to advanced lung cancer. It's actually worse than colon cancer, breast cancer, all other cancer we know. So this is why nowadays we believe that the pulmonary hypertension is a malignant disease, as a matter of fact. It shows all the characteristics of malignancy, proliferation of the cells, decrease of apoptosis. The only difference that there is no metastasis. The mortality as well is as bad as the worst cancer. Unfortunately, because we have, I think, some problem in picking up those patients early, as you can see that the vast majority of patients are picked up, about 70% on a stage 3 or 4 function class. They are very, very symptomatic. So we are not doing a good job in picking up those patients quite early. The data has shown, however, that if we start having better threshold and we start adopting kind of, if you like, screening methods, we can pick up more patients at the early stage of the disease, and we hope that we can improve the prognosis of this very dismal condition. So how can we do that? I think there is 3 mechanisms that we can start thinking about it. Sometimes it's very incidental. Sometimes we do chest x-ray and we find some abnormality suggestive of PH, or we do an echo for different reason and we find high PA pressure. So that could be very incidental. However, I think we need to have 2 things. We have to start looking for early symptoms, which is unfortunately initially is not very characteristic. It's exertional dyspnea, some kind of chest tightness, etc. But what I think more important is to start screening patients at risk, such as HIV patients, people with the portal hypertension, with connective tissue diseases. Those people need to be screened annually in order to pick up those patients quite early. If you look at what should we do, of course, examine history in the early finding. If we suspect PH, then we should go ahead and do echocardiography. Who are the patients to screen? Many, because all those patients are really very liable to get PH. For example, somebody with a family history. I just get a call from somebody from Jordan for a young boy. He was 11 years old, and the mother was very, very concerned because her son was diagnosed to have PH. 2 of his basically sisters died earlier with the same condition. So familial pulmonary hypertension is a true reality. Of course, connective tissue diseases, hemolytic anemia, the pulmonary embolism, the portal hypertension and schistosomiasis, those people need to have annual echocardiography. Those who have long-term COPD and they have symptoms way beyond the COPD criteria. We start with usual things, which is history and physical examination, trying to pick up certain symptoms and signs that improve our threshold in getting further diagnostic thresholds. Of course, chest X-ray is sometimes helpful if you have an advanced pulmonary hypertension. You do find the enlargement of the pulmonary arteries, the pruning of the vessels, etc. But as a screening method, it has very low sensitivity, and the strength of recommendation to do chest X-ray as a screening method is level C. It's based on reasonable, but it's not very good screening tool. ECG is as well not very good to screen patients. although sometimes you can feel or you can get some abnormalities such as right axis deviation, evidence of RV enlargement, the right bundle branch block, etc. But again, the specificity and the sensitivity of ECG as screening tool is not ideal. And again, if you look at the guideline, they give it as strength of recommendation C. Lung function. It's well known that if you look at the lung function, the important part of it is the low DLCO, indicating some gas exchange abnormality. However, recently, the data come from Indian cardiologists who looked at this, and they found that if you look at the ratio between the FVC over DLCO, more than 2, that's having high sensitivity to pick up pulmonary vascular diseases, and the ratio of less than 1.4 going for restrictive lung disease. Until validation of this equation, but I think it makes a lot of sense, then lung function is still not the ideal method to screen patients. Echocardiography is really where the money is, and echocardiography is the test to screen for pulmonary hypertension. And please pay attention when I say screen, because at the moment we do not believe that echo is a diagnostic method for pulmonary hypertension. Echo is quite good as a screening tool, simply because in echocardiography you do not measure the pulmonary pressure, you calculated the pulmonary pressure. So it is a calculation mathematically to really get the pulmonary pressure, and there is a lot of pitfall that can happen in echocardiography. But as a screening tool, I think echocardiography is a perfect tool to pick up the pulmonary hypertension. And echo is helpful in 2 things. Echo is really very good in estimate the PA pressure. It's very good in giving you an assessment of the right ventricular size, thickness and function. You can assess left heart as well to rule out some left cardiac problems such as valvular heart process, diastolic heart failure, etc. But echo as well can give you some diagnostic and prognostic measures, such as looking for the shunt sometimes. So you can do the shunt study, look for the pericardial effusion. You can measure the TAPC, which is the movement of the tricuspid annulus, which is very good as a prognostic measure for the pulmonary hypertension. And you can do the TI index. Many kind of numbers that are helpful in following those patients. But as I'm saying, and I'm repeating, echo is not very good to make establish the diagnosis. It has quite a good, basically, sensitivity, 79 to 100% as a screening tool. VQ mismatch is a must to be done as initial workout. Again, VQ mismatch is not screening tool. It might be screening if you think about chronic thromboembolic PH, because those people, you need to do VQ scanning to look at the perfusion mismatching. Let me remind you that the CT scan, the spiral helical CT scan, although it's very, very good as diagnostic tool in patient with acute PE, it's not yet established as a diagnostic tool for chronic thromboembolic PH. Now, of course, the new multi-slice detector CT might be very reasonable, but we don't have data to say that it's very good as picking up the chronic thromboembolic. And what happens when you do the perfusion scanning, you get what they call the salt and pepper really characteristic. It's kind of areas of mismatch in both lungs. Angiogram should be done if you have an abnormal VQ scanning to assess, to confirm the diagnosis and to assess for the resectability, the surgical basically workup in those patients. As I said, spiral CT scan, although it can be helpful sometimes in picking up central clotting, it's not good for chronic thromboembolic, because sometimes you have very distal small clotting which can be misdiagnosed or missed by patient with a spiral CT scan. Other tests that need to be done, we usually do many blood tests to look for the causes that include a test for the connective tissue diseases, sickle cell, schistosomiasis, liver function test, ultrasound abdomen, and HIV serology. That should be done in every single patient to look at the cause for the pulmonary hypertension. Cardiac cath is the gold standard. Cardiac cath is the test that should be done in every single patient before we start them on treatment. We're going to talk about treatment later on in the evening session, but right heart cath is the diagnostic choice that should be done in every single patient. It has level A strength of recommendation. It has many advantages. It can confirm the diagnosis. You can determine the severity of the disease, look for certain prognostic, basically measurement, exclude left to right shunt, and do what we call vasoreactive testing that we're going to talk about when we talk about treatment. You can get many prognostic markers by cardiac cath that are going to be helpful for you before you start treating the patient. So the algorithm that I look at it at the moment when we would like to screen and diagnose PH, that we need to suspect the PH, and then everybody that you have a suspicion for PH, then you should do an echocardiography as a screening tool. If the echocardiography is really negative and you have low clinical basically suspicion, then probably you should stop there and seek for other cause for the symptoms. However, if the echo is negative and you still have high clinical index, then you should either repeat the echo late in about 3 or 6 months' time, or go directly for right heart cath to confirm or to rule out the diagnosis. However, those who have a positive echo, then you should look if there's any evidence of left-sided problem, and that's going to give you group 2, which is the pulmonary venous hypertension. If the echo does not show any left heart problem, then you need to go for all the tests that we did to rule out the causes. If you can get the cause, then that's fine. You can label the cause. If you cannot label the cause, that's idiopathic PAH, and everybody needs right heart cath. So in conclusion, PH is a fatal, malignant, underdiagnosed process. PH is significantly under or late diagnosed. I'm beyond time. I need another 10 seconds. Thank you. It's all right. It's okay. That's my last slide anyway. Yeah, last slide. So, okay, that's fine. Thank you. Okay, so just like PH is very underdiagnosed, I think we need to start thinking about it in patients who have problems such as exertional dyspnea. Screening is extremely important, and as I said, I think echocardiography is the best screening tool. Other tests are important, such as chest X-ray, ECG. I think the lung function ratio is of interest. If you have a ratio of FVC over DLC or more than 2, you should seriously think about pulmonary vascular disease. But eventually, the right heart cath is the diagnostic test of choice. It does confirm the diagnosis, it determines the severity of the disease, and evaluate the reversibility. I'm not sure what's happening here, but that's fine. I will just try to invite you for our next meeting in Sharm el-Sheikh. It will be in 7th to 9th of April. I think that's Chinese because I'm going to China. So somebody put Chinese basically fonting here. So you are more than welcome to join us in Sharm el-Sheikh, and thank you very much for your attention.
I think we have a couple of minutes for any questions before anyone would like to ask. I think we have a mic. We have a mic. We have a mic.
Thank you for the lecture. Dr. Idris, I think the threshold is different for some people regarding the diagnosis of pulmonary hypertension. I mean, you said that screening, we can use the echo for screening, and when we have the data, we can see that the echo is almost cannot detect the early cases, especially if we don't have a flow through tricuspid regurg or some problem like this. So I'm somewhat confused, and I have some data that when we have a dyspnea which is not explained, and even if the echo is okay, we should go to right cath. And I think this is a school for some people that they go rapidly for right care.
Right.
In our culture, actually, it is not the actual attitude. So how can we solve this problem? Because I think up till now, screening is not, get yet. And what is the role of cardiopulmonary exercise test?
Right.
It's a non-invasive procedure which can differentiate a lot of diseases. Restrictive, obstructive, and pulmonary hypertension is one of the categories.
Sure.
What do you think?
Thank you very much. Now, to go for the right heart cath as the screening tool, I think it's a bit too invasive for screening really process. And it's again expensive that you need to really admit the patient basically for a few hours. You need to really monitor them for pneumothorax, etc. So I don't think it's really practical as screening tools. However, I agree with you that if you think clinically that this is pH and the echo is really negative, then you should proceed for cardiac cath. But I think the sensitivity of really echocardiography is at least 80%. So you are picking up 8 out of 10 at least by echocardiography. So I think because echo is non-invasive, it should still be the screening test before right heart cath. I think most centers take right heart cath as a diagnostic test, but not as a screening test, really per se, simply because it's really very invasive. Going for the cardiopulmonary exercise testing, there's lots of data on that. And people use many endpoints, mostly, of course, the oxygen consumption at the primary endpoint. However, when you look at it, the practicality of doing the cardiopulmonary exercise testing outside the clinical trial is not very practical. For many reasons, because you need to have very kind of well-equipped lab for that, you need to have very good standardization, and sometimes those patients are very, very sick to go and to do the required amount of really exercise. So I think most people use cardiopulmonary exercise as a tool in clinical trial setting. It will be difficult to do it, especially if you want to do tests that can give you some benefit in the 6-minute basically walk distance. But again, this is only prognostic. It's not for screening and not for diagnosis. So the cardiopulmonary, it is really applicable. You can basically do it, but it's going to be much more, I think, complicated to really do that in real life.
Thank you very much, Professor Magdi, for this very comprehensive lecture. And I know your experience in this field of pulmonary hypertension. As you know, COPD is one of our most serious diseases in respiratory medicine. And the relation between COPD and pulmonary hypertension is still very weak.
Right.
Although there are several mechanisms in COPD that should cause elevated pulmonary blood pressure so much, but we don't expect at all in COPD to find severe pulmonary hypertension. And if we find severe pulmonary hypertension in COPD, we should search for another cause.
Absolutely.
So how you explain the absence of high records of pulmonary hypertension in COPD?
Thank you very much. I think if you look at it, you are rightly said by saying in pulmonary in COPD the pulmonary hypertension is not uncommon. However, those people usually they are hypoxic and end stage, and usually their PA pressure in the range by echo in the range of really 40s or so. It's very unusual to find PA pressure of 70s, 80s, or 90 in COPD. And there is two conditions that we go ahead and investigate patients if they get pH in COPD. Number one, if they have pH pressure of 70s, 80s, or 90s, we go ahead and do right heart cath to confirm that. Number one, to the diastolic dysfunction, other causes of the pH. And number two, if you have really out of proportions, for example, somebody who's having mild COPD by lung function, and their symptoms is not very bad at all, but you do an echo and you find PA pressure of 45 or 50, and the patient is not clinically basically hypoxic, and they do not have much symptoms, and the lung function is reasonably okay. Those people deserve further diagnostic basically workup. However, somebody who's having COPD, he's having advanced hypoxia, and his symptomatic lung function is very low, and their PA pressure of 45 or so, we take that as secondary to COPD per se, and usually we do not treat those patients. I have only 2 patients, COPD, that I really treat their pH specifically because they were out of proportion. One of them, they had very high, basically pH. We did a right heart cath, and his mean was 82. So that was very high, out of proportion. And the other one, he had close to normal lung function. FEV1 was only about 72%. But he had high PA pressure, and we treated those people. Most of the time, we don't treat them. We just give them oxygen, bronchodilator, etc., and inhaled steroid. I'm a fan of the inhaled steroid in COPD, although I heard this morning the basic controversy. But we don't treat patients unless we are really convinced that the pH is out of proportion with the COPD.
One of the explanation mechanisms that you get a very high out of proportion pH in COPD years, and that you get the left cardiac dysfunction.
Right. The diastolic dysfunction is extremely common. And actually there's now data, newer data, that you get even systolic dysfunction in COPD because of the systemic nature of the COPD. So yes, you can get left heart problem definitely with the COPD, but the right heart cath is the only diagnostic way by checking basically the wedge pressure. And what we do, sometimes if we get borderline wedge, we challenge them basically with fluid and see what happens. If the wedge shoot up, then that's very good for diastolic dysfunction. We have, yes.
The definition of pulmonary arterial hypertension by the use of cardiac catheterization is mean pulmonary arterial 25 millimeter mercury with pulmonary capillary with pressure less than 15.
Absolutely.
What is the diagnosis of pulmonary hypertension by the use of transthoracic echocardiography? The same reading or the
Okay. Now the echocardiography will give us only this basically right ventricular, basically the systolic pressure. So that will be only the systolic pressure. It will not give the mean pressure, the ordinary echocardiography. So if you look at the data from the clinical literature, they take the basically systolic pressure of 45 or more as the really cut limit between the pH or non-pH. So the systolic pressure of 45 or more. However, when you look at the correlation between echo and right heart cath, you do find a lot of gap between them. And we have data on really, basically our data, more than 40 millimeter equivalence, really difference between echo and right heart cath. What I think the echo is good is correlation, that if the right heart cath is basically going up, basically echo is going up. This is going down, this is going down, but the number will not be in a way similar. So this is why we're saying the number of 45 by echo, if that's really the threshold that makes us think that there is pH. If it's less than 45, that's borderline.
I think we have one question, because we had a panel discussion which I had in the session.
The difference between management of primary pulmonary hypertension and secondary pulmonary hypertension.
Difference in mental. Can we leave that, the evening session? Because of the evening session, we're going to talk about this question. In the evening session, in about 1 hour from now.
By the way, there is no second primary hypertension. That's a new definition.
That's right. So we're going to talk about this.
The non-pH classification. So I think we go for the third discussion. I'm looking for a many onward.
Yes, depends on the time. Do you have time for that, or do you want to go for the panel? Okay. Now the second talk is about the pulmonary vascular diseases, but it's a bit different. Now we're going to talk about the pulmonary embolism. This talk was supposed to be given by Dr. Siraj, basically Wali, but he couldn't make it. So I did some modification myself on this. So. Now let me remind you that the pulmonary embolism is a syndrome that was detected more than 100 years ago. And the Picard was actually amazingly talking about the pulmonary embolism when he said venous thrombosis is always a severe disease and it's often fatal because fragments of the thrombi may detach and occlude the branches of the pulmonary artery. The occlusion of the main branches of the pulmonary artery causes a striking rise of the blood pressure in these basically vessels. This rise, which the right heart might fight in order to ensure circulation, may sometimes lead to cardiac arrest. And that's amazing That's the exact pathophysiology that we understand 100 years later. If you look to our definition at the moment of the massive PE, it's very much similar to what Pocket said 100 years ago. It's a clinical syndrome of high mortality characterized by acute basically pH occlusion and results sudden elevation in the pulmonary artery pressure and right ventricular failure. I think when we make a diagnosis of the pulmonary embolism, the first step is to risk stratify the condition, because it's very important to know is this uncomplicated simple pulmonary embolism where the mortality is almost zero, or this is a complicated massive or submassive PE that it deserves better basically attention. If you look at the definition of the massive pulmonary embolism, it's been different in the literature. Somebody used the visual scoring, such as when you have more than 50% defect in the perfusion scan, but most people agree that probably number 1 and 2 here, that there is severe refractory hypoxia and or hemodynamic instability, i.e. The hypotension. Of course, the acute right ventricular failure is very characteristic for the submassive PE and might lead to the low urine output and tissue hypoxia. So this is, I think, a very important slide I look at it because that explains the whole lecture. I think this is where should we make up our mind when we see the patient. Is he in cardiac arrest where the mortality is almost 70%? Is he at shock status where the mortality is around 20 to 30%? Or he's on the curve below the shock status when the pulmonary hypertension is there? However, it's important to know that there is some patient in this area here that they have RV dysfunction, but they are not yet having basically shock status. And it's very clear that the mortality of those people is really increasing drastically from 0% to 30%, an average of about 8%, without clear documentation to what we are looking at, because those people are stable hemodynamically, they have close to normal oxygenation. So I think those people, the difficulties is knowing where is this inflection point, where is this curve is going up, and how we can pick up this inflection of the curve and the increase in mortality. Let's take it one by one. If you look at the cardiac arrest, I'm going to show you only one slide. Cardiac arrest people, the mortality is extremely high. If you have patients with a PE, we know that really the outcome is extremely bad. The vast majority die. But there's only one thing that we'd like to draw your attention to, is to use of the thrombolysis treatment in patient with cardiac arrest, because I usually hear these things that the patient had a CPR, so the TPA or cytokinase is contraindicated. I think this is definitely there is no good control trial, but at least based on the case report, thrombolytic treatment in those kind of patients can be life-saving, even if they have aggressive CPR and the pulmonary embolism is in the diagnosis. Those patients should receive a TPA, and you can see that at least out of case report, in about 70% of them, you can reverse the arrest status. Those who have shock but not yet cardiac arrest, they are in hypotension. Hippocrates, long time ago, said very interesting phenomena. He said, in acute disease, coldness of the extremities is a very bad sign, and indeed that's the case, because that indicates a case of the shock status and the vital organ hypoperfusion. If you look at the mortality in pulmonary embolism patients, it's very clear that the shock is the really line where the mortality increases, and the average death, if you have shock status, is about 30%, while if your patient is not in shock status, the mortality is far lower, in the average of 0 to 5% or so. So, should we thrombolyze patients who have pulmonary embolism and shock? I think if you ask anybody, that everybody going to say yes, because if you have shock status, TPA or cytokinase or urokinase or so on, they accelerate the clot lysis, they improve the hemodynamics, and they might improve the mortality. Now let me show you what is the evidence. Actually, the evidence is very intriguing. If you look at it, it was a single study, looked at lytic treatment in a massive PE. And this was a randomized trial aimed for 40 patients between heparin and thrombolysis. And the diagnosis was based on low blood pressure and the use of kinase. This paper was prematurely terminated simply because there was only 8 patients assigned. All 4 patients who received the cytokinase basically survived, and all 4 who were on heparin, they died. So the author believed that they should terminate basically the paper because it was not ethically kind of acceptable to really continue. However, when people looked and reanalyzed the data, they found that those patients who received heparin, they were older, they were sicker, and they had more oxygenation problem. So based on this study of 8 patients, nowadays we are taking it as we should go ahead and thrombolyze everybody with a massive PE. And at the moment, it is the standard of care to really thrombolyze patients with a massive PE, but you need to keep up your mind that the available evidence is based only in one study. What about those patients who are borderline? That they occur here. Clinically they are fine, they are having stable hemodynamics, but they have documented basically pulmonary embolism. The question where they are basically falling, are they here, are they here, are they here? So our job in the clinical practice, especially in the acute setting, trying to pick up where is the patient in which line of this care. And there is a lot of data about how to stratify those patients, going from some clinical background about the age of the patients, comorbidity, tachypnea, etc. And there is some investigation tool that we should do trying to pick it up, starting from the chest X-ray and ECG criteria, going to the biomarkers of the BNP level and troponin, doing for echocardiography, assessing right ventricle, and the CT scan. Recently, the multi-slice detector CT scan ratio between RV over LV ratio, more than 1. What I'm going to talk about today briefly is those 2, the biomarkers and the echo, to checking that. If you look at the biomarkers, the 2 important ones are the BNP, the brain natriuretic basically peptide, and the troponin. In theory at least, the BNP assists the stretching of the right ventricle, while the troponin assists the ischemic insult. However, both of them assist right ventricular dysfunction and damage. The data is clear to show that whenever you have high BNP or high troponin, the prognosis or the outcome of those patients is much worse than those patients who have normal troponin and normal BNP. Echocardiography is another very good assessment tool to detect the patient who are at higher risk and probably increase mortality in the way that you can assess right ventricular dilatation, the synergy or the asynergy in the RV wall function, the paradoxical septum, tricuspid regurg, and you can look for the patent foramen, basically ovale, the clot, etc. So both of these tests are extremely important tests to stratify your patient when you have an acute PE. However, when you come to the treatment-wise, saying, should I thrombolyze those people who have abnormal echo and they have high BNP level? Data is giving you controversial issue there, and you can see that there is many data in the literature, but give you very close mortality, whether you thrombolyze those people or not. 3.1 for those who received lytic treatment, and 3.7% of those who received only heparin. Recent study trying to look more in this, and they actually have a good number of patients, 256 patients who have stable hemodynamic, basically pulmonary embolism, but they have an abnormal RV in echocardiography. And the primary endpoint was the in-hospital mortality, while the secondary endpoint was 30 days mortality or the recurrence of the pulmonary embolism. When you look at it, when those people look, the composite endpoints, everything, in-hospital mortality, 30 days mortality, recurrence of PE, acceleration, need for ICU admission, there was difference that those who receive TPA, they get better outcome. However, when you look at the mortality per se, in hospital mortality, there was no difference between the two groups. So again, this kind of paper showed that maybe TPA prevents the escalation of the condition, but per se, it does not improve survival. So the big question, why thrombolysis does not improve survival in the submassive PE? Let me show you, we were thinking about this in our group back home, and we thought that maybe the clot per se is not the important aspect in the submassive, basically pulmonary embolism. Let me ask you one question. Now, when you do Swan-Ganz and measure the wedge pressure, when you occlude one of the pulmonary artery, that's an occlusion process. Those patients do not get acute PH. When the surgeon ligates the pulmonary artery for pneumonectomy, those people do not get PH. And the question is, why is that? Although this is a very significant obstructive load. So why, if I occlude the pulmonary artery, I don't get a PH? While if you have small thrombus, I occlude it. I think the idea came of our now understanding that it is not the clot per se. It is the neurohormonal release in the circulation that lead to bilateral vasoconstriction, increase in the pulmonary vascular resistance, and right-sided heart failure. So we thought we should do something unique. We thought we should treat submassive pulmonary embolism not by TPA, by targeting the pulmonary vascular resistance, by the pulmonary venodilator. And we chose the prostacyclin because it has anti-inflammatory effect, it has vasodilatation effect, and it has some antiplatelets effect. And we use ileoprost, inhaled ileoprost, simply because of the local effect and avoiding the systemic hypotension. So we had 5 patients who had submassive PE. They were stable hemodynamically, but they were having abnormal echo, very high NT-proBNP and troponin. And we gave them heparin plus inhaled ileoprost. And our primary endpoint was the functional class and the exercise, but we looked for other markers as well. And this is what we find out. When we look at the function class, we gave them 3 weeks of inhaled ileoprost treatments. And as you can see, in 3 weeks, if you look at the average in those patients before and after ileoprost, they moved in average from NYHA class 3 plus to NYHA class 1. So there was significant improvement in their functioning class. Their Borg dyspnea scoring improved dramatically from average of 8, which is very severe dyspnea, to average of 1, which is very, very mild dyspnea. Their 6-minute walk distance improved from 150 meters to about 450 meters. So they were able to walk 300 more basically meter when we gave them inhaled ileoprost, really targeting not the clot itself, the vasoconstriction in the vasculature. And their BNP dropped from average of 1500 to go down to 300, and their echocardiography improved, and the systolic PA pressure dropped from 80 to about 38. We thought this was very interesting observation, and now we are having a randomized clinical trial in many centers in Saudi Arabia trying to really test this basically theory. We are happy to have any centers in Egypt if you are interested to be basically part in this new theory, I'll say. So in summary, the pulmonary embolism is a complicated syndrome. It could be potentially serious, so risk stratification is extremely important. We believe that we need to be sure are we dealing with a simple and complicated PE where the mortality is almost 0, or those who have somewhere submassive PE where the mortality is substantially increased to 8%, shock status, or cardiac arrest. We believe that thrombolytic therapy is the standard of care in a massive pulmonary embolism, but you need to remember that was only based on one study. The lytic treatment is still controversial in the submassive PE. I think our theory of really targeting the PVR and not, I'm done as well, sir, and not the pulmonary embolism per se is an interesting, basically, phenomenon, and I'm willing to take any question for that. Thank you very much. Thank you. Go ahead.
Thank you very much for your extremely valuable talks, and I think it's time for questions in panels. We can have the moderator provide. Thank you.
Yes. Question? Yes, please.
Thank you, sir. Very nice presentation. My question is about there is getting of that. Thank you, sir, for this very nice presentation. Their statement is that therapeutic window is very narrow in thrombolytic therapy. So, after how many hours can I give it safely?
Thank you very much. Now, for the pulmonary embolism, data has looked for immediate TPA, 5 days TPA, 14 days TPA, 21 days TPA after the attack. And they found if you thrombolize them basically within 2 weeks, you are okay. It is not like the acute MI, for example, that you should go immediately. In the acute pulmonary embolism, you have up to 2 weeks basically window to really thrombolize those patients. You want to take another question? Yes, please.
Small patients of pulmonary embolism develop pulmonary arterial hypertension later on.
Right.
Is there a study or studies make this an end point for the effect of thrombolytic therapy? Who will develop pulmonary arterial hypertension?
Right. Apparently there is no long-term studies, but there is assumption because you are reversing the process acutely. So probably lytic treatment probably can decrease the prevalence or the incidence of the chronic thromboembolic in the massive pulmonary embolism. We don't have this data in the submassive pulmonary embolism. But in the submassive PE, it's one of the speculated endpoints. But there is no long-term trials to really say that this is the case. Because as I showed you, there's only 8 patients in the literature who received cytokines with a massive pulmonary embolism. So it's very difficult out of those 8 patients to make a solid diagnosis. But we assume that if you give lytic treatment early enough, within basically 2 weeks, you decrease the incidence of the chronic thromboembolic PH.
We have to stop here the question because we have a panel discussion. By the way, we have another session at 7:30, which we have the same topic, the same pulmonary hypertension session, and the faculty should be with us. So, thank you.
بسم الله الرحمن الرحيم. الصلاة والسلام على سيدنا محمد وعلى آله وصحبه وسلم أجمعين. Welcome again in our scientific meeting. Grateful thanks for Professor Tarek Mahfouz who gave me the chance to share our eminent professor in this interesting and important session. The first question about this session, the best management for cardiac arrest due to massive pulmonary embolism. All known that more than 50 to 70% of causes of cardiac arrest in emergency room is due to massive pulmonary embolism or MI. So we want to know now from the floor what is the best answer as regards the management. Cardiopulmonary resuscitation only, or start immediately thrombolytic infusion and continuous CPR through infusion, or thrombolytic infusion after CPR and patient become again, or unfractionated heparin infusion with cardiopulmonary resuscitation. Can vote please? I think that the majority choose the third answer, which about start thrombolytic infusion after CPR, and I think this is not the correct answer. Please, Professor Adil Imam can give us a comment about the correct answer.
Actually, cardiopulmonary resuscitation after giving thrombolytic therapy is very dangerous and hazardous because of the thrombolysis which happens. So I would prefer doing the cardiopulmonary resuscitation first and then give the thrombolytic therapy.
There is some research and the Society of Cardiopulmonary Resuscitation about that the role of thrombolytic therapy with CPR may be helpful to avoid long-standing cerebral ischemia. As thrombolytic therapy alone, patient can be still alive and return back, but unfortunately will be a cerebral ischemic change. What your advice, Dr. Adil, about this opinion?
Yes, it becomes very difficult to get thrombolytic therapy and doing. I would start with cardiopulmonary resuscitation and give after this, if the condition allows, will give the thrombolytic therapy.
Why don't you give two? I mean, you start with CPR as well, you give the infusion.
That's what I mean.
The two.
Yes, that's what I mean.
Second question, Dr. Sameh, please. As regards the same point that previous Professor Bagdi Idris about risk stratification in acute pulmonary embolism, principal markers useful for risk stratification in acute pulmonary embolism. Cardiac markers like brain natriureteric peptide or pro-brain natriureteric peptide, echocardiography as regards the picture of right and left ventricular dilatation, hypokinesia, and pressure overload on echocardiography, elevated D-dimer, or abnormal perfusion scale. Please go. I think the majority now is in the correct answer. It is about the cardiac marker. Please, Professor Hussein Ali Hussein can give us a comment about this question. Third question, please. Now, what about the best regimen for pregnant woman with acute hemodynamic stable pulmonary embolism? Is low molecular weight heparin during first trimester followed by vitamin K antagonist, unfractionated heparin for 5 days followed also by vitamin K antagonist throughout pregnancy, or low molecular weight heparin weight adjusted regimen, then to be stopped before elective delivery and resume again after 12 hours. The last choice, intravenous thrombolytic therapy followed by low molecular weight heparin or unfractionated heparin. Vote please. I think that also the majority of the floor take the correct answer. It is about low molecular weight heparin weight adjusted dose. Please, Professor Muhammad Al Sabur can give us a comment about this question.
for that question is the correct answer, because as you know that the vitamin K antagonist and children before pregnancy, the first, second, third trimester, introduce the multiplier of use during pregnancy, but the optimal is to use during reproductive during all the pregnancy period and to stop it after that 24 hours before delivery and during the age of 12 months.
Thank you, Professor Mohammed. And just a comment, what's your opinion about vitamin K antagonist? Some cardiologists prefer to give in certain selected cases. But still up to now, I think there is not absolute contraindication, so I think this is your opinion again. Thank you, and unfortunately you cannot continue the question as time now is too late for the second session.
This session, the topic will be the new specific practices.
بسم الله الرحمن الرحيم. انا طبعا سعيد ان انا اتكلم تاني النهارده وبحيي كل الحضور. يعني انا شخصيا رغم ان انا كان لازم اجي عشان انا هتكلم، لكن فعلا الحضور دول لازم كلهم ياخدوا جوائز، لان الواحد ما لحقش يستريح، ما لحقش ينام بالليل، ودلوقتي في جلسه، فان شاء الله ما تكونش التوك تقيله على حضراتكم. الحقيقه قبل ما ابتدي انا عايز اشكر الدكتوره ايمان حسن مدرس الصدر في عين شمس. هي بنتي اكشوالي، واتمنى انها يعني كانت تكون بنتي فعلا. هي بنتي كده الابوه العلميه، انا بفتخر بيها. الحقيقه هي ساعدتني كتير قوي قوي في المحاضره دي. الزونوزيس هو الديزيز كان بي transmitted from other vertebrate animals to human. الديفينيشن ده modified to include all human diseases that are acquired from or transmitted to any other vertebrate. طبعا لسه طويله وانا الوقت هيقفل عليا، انما زي ما حضراتكم شايفين لسه طويله وعريضه. نبتدي بالبليج اللي بيسموه البلاك ديث. ده bacterial infection most often transmitted by bites من infected fleas. الفليز بتبقى infected by feeding on an animal يكون عنده اليرسينيا بيستس بكتيريا في البلاد ستريم، وبعدين typically الانيمال بيبقى infected من different wild rodent species. ده بيعمل infection through the lymphatic system وفيتال في 50% of people infected who do not seek treatment. النمونيك form of plague طبعا ده الموست virulent and least common form of plague الحمد لله. البرايمري pneumonic plague results from inhalation of aerosolized infective droplets can be transmitted من human to human without involvement of fleas or animals. An untreated pneumonic plague has a very high case fatality ratio. دي خريطة بتبين WHO من 2002 ل 2005 اللي بالاحمر دي الكانتريز notified cases to WHO. الكانتريز الثانية دي اللي ما كانش فيه notification. سيتاكوزس ده طبعا الاورجانيزم اللي هو الجايميدوفيليا سيتاسي في الستيتس مش common 15 cases per year. السورسز السيتاسين بيردز especially الدجاج والكوكتيل wild birds. الترانسميشن aerosols from dried feces or respiratory tract secretion من البيردز. mouth to be contact handling lung or tissues. An incubation period من 5 days to 2 weeks والseverity بترينج من unapparent infection to severe pneumonia. السيمتومز زي السيمتومز of pneumonia مفيش اختلاف. والdeath used to occur due to respiratory failure and hemorrhage. Laboratory confirmation culture culture respiratory secretion complement fixation or microimmunofluorescent والPCR. الهانتا فيروس ده فيروس single stranded RNA فيروس. في انواع منه، في الهانتا فيروس بالمونري سيندروم والهانتا فيروس فيفر with renal syndrome. الاونلي فيكتور للمرض ده هو الرودنتس، والريبورتس بتقول ان في 20 to 50 cases per year in the states. دي انواع الرودنتس اللي ممكن بتنقل الهانتا فيروس. الترانسميشن contact with rodents او aerosol transmission of the virus from dried excreta or saliva. Less commonly dried excreta or saliva in broken skin, eyes, contaminated food or water. Incubation period 1 to 4 weeks. هو بيبتدي فيفر وماسل generalized manifestation الهيدك والchills والديزنس وبعدين الكوف وبعدين rapid progression to severe respiratory distress. ممكن يحصل this with pulmonary edema و decrease in lung function and hypotension. في 5 overlapping stages في الهانتا فيروس فيفر. الفلو لايك illness فبرايل، بعدين hypotension تلتهم بيحصل this. الاوليجوريا، هايبوفليميا، دايوريتك والكونفاليسنت. برضو الدايجنوزس سيرولوجي الايزا الاي جي ام والامينو هيستوكيمستري والبي سي ار. الكيو فيفر الاسم الثاني 9 مايل فيفر الكوكسيالا برونيتي زي ما حضراتكم عارفين، برضو uncommon disease في الستيتس. السورس الهوست اوف دوميستيك اند وايلد انيمالز primarily الشيب والجوتس والكاتل. Transmission contact with infected animals or their products, usually inhalation of bacteria in dried excreta or the placenta, can be transmitted to fetus from a symptomatic pregnant mother. لكن الحمد لله no person to person transmission. Incubation period من 2 to 3 weeks. ممكن يبقى acute infection، ممكن يبقى chronic. برضو اللاب كونفirmation سيرولوجي الاندايركت immunofluorescence في الاكيوت فيس الاي جي اي تو فيس 2 والاي جي ام تو فيس 1 and 2 والبي سي ار. طبعا البيرد فلو الافيان انفلونزا، واحنا للاسف بقينا في 2009 انديميك كانتري في الافيان انفلونزا. العالم كله في 2009 لغايه النهارده في 48 حالة، 37 منهم في مصر. الحالات معظمها عندنا، لكن الحمد لله هما 3 دول، فيتنام 4 حالات ظهروا سنة 2009 والأربعة ماتوا. في الصين 7، 4 منهم ماتوا. 37 حالة في مصر، 4 ماتوا. فاحنا اللوست مورتاليتي لكن اكبر عدد. الافيان فلو طبعا مش هتكلم عنها، معروف كلنا عارفينها. زي ما بقول احنا عندنا 88 بوزيتيف كيسز في مصر، و37 حالة في 2009، 4 دايد. لكن المورتاليتي هو ابتدى عندنا في 2006 بتتحسن، كانت 56% المورتاليتي، السنة اللي فاتت 50%، السنة دي 11%. لكن avian flu became endemic in Egypt. انا هقول حاجة هي مش سر طبعا. وزارة الزراعة مع القطاع البيطري في وزارة الصحة عملوا بحث، نزلوا خدوا عينات من 50 سوق للأسواق اللي بتباع فيها الدواجن. بياخدوا مساحات من البولتري، الدواجن اللي بتتباع، لقوا 20% من الدواجن اللي بتتباع فيها H5N1. طبعا ما فيش مشكلة للأكل، حضراتكم عارفين هو بالأكل دلوقتي. طبعا القصة اللي كنا فيها قبل الغداء اللي حضر المحاضرة H1N1، قصة طبعا المشكلة انه بيحصل الانفكشن من السواين ده في البداية، ظهرت في البداية، وظهر الشهر اللي فات برضو حالات انفكتد من سواين. وبعدين اللي حصل في السواين هو المخلوق الوحيد اللي ممكن بيحصل فيه ان الفيراي تتجمع مع بعض، الفيروسز. بداية ال H1N1 في مارس في المكسيك كانوا 4 انواع من الفيروسات. الفيروس بتاع السواين، وافيان، سواين بتاع اوروبا وسواين بتاع امريكا، مع افيان، مع سيزونال. الاربعه دول نتج عنهم ال H1N1 اللي هددت العالم من مارس حتى الان، والترانسميشن لملايين الناس. برضو انا هعيد بس من اللي ما حضرش، احنا الموضوع عندنا ايه لغايه امبارح؟ الريبورتد كيسز 3520، 23 منهم دايد. نسبه المورتاليتي في مصر 0.7%، يعني 7 في ال1000. الجلوبال مورتاليتي 1.1. طبعا الكونفيرمد غير الاكتشوال. WHO بتقول انه في من 120 ل 180 مليون واحد خدوا ال H1N1 من مارس. من 120 ل 180، ما عندهمش حصر. لكن الكونفيرمد لابوراتوري 1,041,000 وشويه. والجلوبال مورتاليتي زي ما قلت لحضراتكم 1.1 او 11 في ال1000. ستيتس المورتاليتي فيها 4314 لغايه يوم 23 نوفمبر. الكاونت ما اتحركش بعد كده. السعوديه مش برضو عشان مقارنه بالسعوديه، لان السعوديه بخلاف انها دوله جنبينا، السعوديه عندها مشكله في الديزيز ده، انها يعني 25% من البوبوليشن اكسباتريتس جايين من بره، بخلاف الحج والعمره. فطبعا العدد زي ما حضراتكم شايفين اكتر من 9300 و9 في ال1000 المورتاليتي. البرازيل والارجنتين اللي حطيتهم ليه؟ لان هم الدول دي اول دول ظهر فيها الحالات في شهور يونيو ويوليو اللي كانت شتاء عندهم. هم ما كانوش ماشيين بريجوليشن صح اللي احنا ماشيين والعالم ماشي بيها دلوقتي طبعا. ال WHO كانوا بيعملوا هوسبيتاليزيشن لكل الحالات، فدخلوا الحالات السيمبل. اما جت الحالات السيفير ما لقيتش مكان في المستشفى، فماتت بره المستشفى، عشان كده المورتاليتي عاليه. انا طبعا احنا عندنا 23 حاله، 19 حاله عندهم ريسك فاكتور، 4 ما عندهمش. دي الريسك فاكتورز اللي في حالاتنا: البريجننسي على راس القائمه، uncontrolled diabetes، cardiac problems، liver impairment، COPD. حاله واحده بس ازمه رغم الكلام اللي بيتقال على الازمه. عندنا حاله acute renal failure، حاله كان فيها فيوكروموسايتوما و رينال ترانسبلانت وكرونيك رينال فيلير في حاله، وزي ما قلنا 4 حالات من غير ريسك فاكتورز. نرجع لمرض اخر، زونوزيس الانثراكس. ده برايمري ديزيز اوف هربيفورس ماملز. الهيومن جنرالي اكوارد ديزيز دايركتلي او اندايركتلي من الانفكتد انيمال او اوكيبيشنال اكسبوجر. الكوزتيف ايجنت هو الباسيلس انثراكس. 3 تايبس: في الكيوتينيوس من السبورز عن طريق السكين، او جاسترو انتستاينال، او بالمونري من الانهيليشن. انا طبعا لازم اجري بسرعه عشان ما بحبش ان الوقت يخلص مني والموضوع طويل قوي. عايز اكتر من 20 دقيقة. الهايداتد ديزيز طبعا. الهايداتد caused by echinococcus، ده زي ما حضراتكم عارفين parasitic cystode من البلاتي هيلمينثس commonly referred to as tapeworm. 3 forms ممكن تحصل في الهيومن. السيستيك فورم echinococcus granulosus، الالفيولر عادة بتبقى echinococcus مالتي لوكيولاريس، وفي البوليسيستيك. الهايداتد affects the lung في 22% of the cases where present chest pain, cough or hemoptysis. The other organ affected include liver, abdomen, pelvic cavity, spleen, kidney, heart, brain. دي اللي بيحصل. الادلت في السمول انسيستد بيبقى بعد كده الامبريونيتد ايج، ده اللي بيحصل من طريقه الانفكشن، وبعدين الاونكوسفير هاتشز وبنتريتس الانتستينال وول. الهايداتد سيست بتبقى موجوده في الليفر واللنج، وبعدين البروتو سكوليكس فروم سيست، وبعدين السكوليكس اتاتش تو ذا انتستين. الانترميديت هوست بيبقى الشيب والجوتس والسواين، والديفينيتيف هوست هو الدوج والاذر كانالز. دي الارياز اللي فيها الهايداتد. احنا برضو مصر بتعتبر من الانديميك ارياز بالنسبه للهايداتد. Another important disease هو البروسيلوزس. 3 species، البروسيلا ابورتس والسيوز والمالتنسس من الجوت والشيب. Although pulmonary symptoms accompany up to 16% of cases of infection من البروسيلا maltensis, pleural effusion has rarely been reported. البرزنتيشن بيبقى fever, cough, mucopurulent sputum. الاكس راي بتبقى pneumonic patches, consolidation وpleural effusion وgranuloma, pulmonary nodule with or without enlarged mediastinal lymph node and interstitial pneumonitis. البكتيريا enter the body through mucous membranes ويحصل spread through lymph nodes والسبلين. If pregnant, البكتيريا invades the uterus, placenta, restricting the transfer of nutrients to the fetus وتعمل toxins potentially leading to fatal death or the birth of an infected fetus. ده المنظر بتاع البروسيلا سبيشيز. الليبتوسبيروزس انفكشن رودنتس برضه والاذر وايلد والدوميستيك سبيشيز. الاكسبوجر عن طريق الووتر كونتامينيشن باي يورين from infected animal and the most common routes of infection. Human to human transmission is rare الحمد لله. Pulmonary presentation hemoptysis, respiratory failure, pulmonary hemorrhage و ARDS. كنت مرة كان في ميل كده بينتشر، قريت ان في ناس جالهم ما عندهمش احتمالات رودنس خالص وجالهم الليبتوسبيروزس، واما بحثوا لقوا ان هم الكنز اللي بيشربوها بتاعت البيبسي او غيره، الكنز دي هي بتبقى متخزنه في مكان فيه الرودنس دهوت، وهو بيجي بيشرب الكان ما بيكونش نظفها فاتنقلوا العدوى بالطريقه دهيت. توكسوبلازموزس parasitic disease caused by البروتوزوا توكسوبلازما نادي. parasite infects most genera of the warm-blooded animals including الهيومن طبعا. البرايمري هوست بيبقى عائلة القطط. الانيمالز infected by eating infected meat by ingestion of feces of a cat that has itself recently been infected. Cats have been shown as a major reservoir of this infection. Up to 1/3 of the world's human population is estimated to carry مجرد carrier toxoplasma infection. أثناء الفيرست few weeks الانفكشن typically causes mild flu-like illness or no illness. وبعد كده يبتدي البارازايت rarely cause any symptoms in other healthy adults. However, people with a weakened immune system such as infected with advanced HIV or those who are pregnant، بنركز على pregnant دي عشان الديزيز دهوت may become seriously ill and it can occasionally be fatal. اللنج البلمونري توكسوبلازموزيس is relatively rare in otherwise healthy subjects. Presentation life-threatening pneumonia due to toxoplasma infection. Clinical والimage based findings overlap with those for atypical pneumonia. Botulism, rare but potentially deadly illness characterized by muscle paralysis. استاذنا الاستاذ دكتور حسن يفتكر الحالات الناس اللي كانوا عندنا في شم النسيم من قبل ما يبقى ده يمكن من 15 20 سنه دكتور حسن ما يبقى المصل متوفر، وحضرتك كنت جبت لهم المصل من فرنسا. بوتوليزم از كوزد كان طبعا جالهم زي ما هنشوف ريسبيريتوري ماسل باراليسيس واحتاجوا يتحطوا على الفنتليتر. caused by nerve toxin that's produced by bacterium called Clostridium botulinum. The bacteria found naturally in the soil. The bacteria grow in improperly canned or preserved foods. اشهر حاجه عندنا في شم النسيم الفسيخ. They can produce the botulinum toxin. Three main kinds of naturally occurring botulism: الfoodborne, الwound, والinfant. The fourth kind بيبقى inhalation affecting the lungs. Can happen when the pure toxin is released into the air and a person breathes it in. Foodborne botulism is severe, potentially fatal disease caused by the consumption of food contaminated with botulism toxin, which is produced by gram-positive anaerobic spore-forming bacterium Clostridium botulinum. The botulinum toxin is the most potent biological toxin known. في 7 potent neurotoxins موجودين. الانجستد توكسين absorbed من الانتستين inhibit release of acetylcholine في النيوروماسكولار junction leading to acute flaccid paralysis. الكلينيكال سيندروم بتاع البوتوليزم في cranial neuropathies and symmetric descending flaccid paralysis and in severe cases وده اللي كنا شفناه severe muscle weakness. الثيرابي هيبقى الاكواين botulinal antitoxin and intensive supportive care. المورتاليتي ريت اوف foodborne botulism varies من 5 ل 15%. الحالات دي بتموت بريسبيريتوري فيلير. الريسبيريتوري فيلير هو الميجر كوز اوف ذس. botulinum toxin is categorized as a class A biologic agent by the center of the CDC. في البيولوجيكال وور بقى ده من الحاجات اللي بيستخدموها. Thank you so much for your kind attention.
Thank you very much, Professor Rahad. Very good presentation and تجميع جميلة وحضرة شريفة يعني أول مرة تتجمع كان present أحسن العميد الفاضل أستاذ الدكتور حاتم الدواني رئيس قسم الصدر اسكندرية، وهو مساعد المحاضرات الشيقة spoke today about diagnosis of pneumonia, facts, and
في laser point. بسم الله الرحمن الرحيم. دكتور عصام دايما بترفع من روحي المعنويه. ربنا يسعدك. هو الثيم بتاع الكونفرنس الحقيقه controversies in pulmonology which is a very good title، لان الطب ليس من العلوم الثوابت، يعني فيزيكس والبيزك ساينسز ماث فيها ثوابت. الطب الثوابت بتاعته يمكن في البيزك ساينسز، لكن طول ما احنا clinicians we are confronted by diseases لابد يكون في debates and challenges. And pneumonia, as far as diagnosis is concerned, is not an exception. Starting by some facts is not enough at all to say that this case is pneumonia. No, you have to describe it in terms of category. Is it a pneumonia contracted in the society, CAP, in the hospital, HAP, or it's in a unique condition in certain patients due to aspiration, or it's a severe pneumonia
occurring in the immunosuppressed patient, because this classification will be of much help. Since if you can categorize a patient according to these categories, then you can describe your patient, the offending organism, the profile of the infection, the selection of antibiotic, and consequently the prognosis of the case. Other facts are that cap and HAP may be life-threatening catastrophes. Sometimes pneumonia is spoken of as a simple disease, but sometimes it's fatal, and the mortality in CAP is 1 to 5% in the outpatient setting, but it may rise up to 12% in patients who need hospitalization, and might even be 40% in specific situations. HAP is a different condition. The mortality rate is extremely high. To diagnose pneumonia, we have to ask a very important question. Are we actually dealing with a case of pneumonia, or is something else? If you decide that it is pneumonia, you have to decide about its severity. Where are you going to treat your patient, at home or in the hospital? If in the hospital, in the ward or in the ICU, then you are seeking for the etiological factor or agent, and consequently you will select your proper antibiotic. This diagnostic workup will entail clinical, radiological, and bacteriological evaluation. All of these tools sometimes are not specific and debatable. If you come to clinical diagnosis, the fact that pneumonia presents by acute onset of fever, chest pain, production of sputum, and hemoptysis. This is a fact. But this fact is not always present, is not always obeyed. In so many cases, this presentation from the symptomatology point of view is not such a classic. In some cases, particularly in the so-called atypical pneumonia, the clinical presentation is totally away from this classical presentation. It's as well a typical presentation. Fever might not be so high. Respiratory symptoms may not be very marked, but they are overshadowed by extrapulmonary manifestations, such as severe unexplained anorexia, GIT manifestations, cerebral manifestations, and agitation. And this actually occurs in all the people. In the LD sector, this is very important. In all the people, presentation may be by just extrapulmonary manifestations, particularly depression and even agitation, some neurological deficits. And later on, you will describe by radiology that you are actually dealing with a case of pneumonia. The clinical signs themselves may not be very marked. We know that pneumonia presents mostly by consolidation, but this actually depends on the stage of pneumonia you are dealing with, because most of the patients, before they are subject to clinical examination, they take some improper antibiotic, which will modify certainly, but will not cure the consolidation. And again, it depends on the segment or subsegment involved. Is it accessible for clinical examination or not? The general physical signs as well are very important. If you rely, for example, on leukocytosis may not be present in atypical and viral pneumonia. On the contrary, severe leukopenia may be present in normal persons, but this pneumonia was severe enough that it causes septicemia and bone marrow depression. So this is an important sign. Severe leukocytosis and severe leukopenia are equally important and ominous signs for severity of pneumonia. Radiological diagnosis. The fact is that pneumonia is a radiological diagnosis. You can't swear that this patient is pneumonic just on clinical grounds. And all guidelines in the world, all global guidelines, classify and describe treatment and everything about pneumonia based on this basic diagnosis. Diagnosis is based only on radiology. So X-ray is mandatory. But the debate is about the time of appearance of the shadow in the X-ray. Sometimes symptoms will precede the radiological signs, and the reverse is true. Another very important point is when to re-array the patient. If you have a patient with pneumonia, definitely pneumonia, and receive treatment, Are you going to do an X-ray every day, for example, every other day, after 3 days? No, this is a debatable point, but the good practice says that if your patient is doing well, is improving, and is steadily improving, postpone any undue exposure to radiation. Just do an X-ray after 5 days. The patient has been cured from the clinical and bacteriological and hematological points of view, then postpone any further exposure to X-ray just after 2 or 3 weeks during a routine office visit. This is what is described globally, but I am sure that, and I think you are also sure that this is not obeyed here. In private hospitals, the X-ray is done every day, which is not a good practice. What about CT? The fact is that CT is not required so long as you diagnose the case on clinical and radiological grounds. You do CT in certain situations. If the patient after 72 hours is deteriorating, if the patient did not improve or showed any even minimal signs of improvement after this duration, you can do a CT. Or if you're suspecting from the beginning that this is not a straightforward case of pneumonia. For example, it's a pneumonia on top of obstruction by a neoplasm or whatever. But CT should not be utilized as a routine investigatory method for documented cases of pneumonia. These are the mimics of pneumonia. This will cause debate. We have so many conditions in an X-ray of a patient presenting by infiltrates, and it ranges between congenital, inflammatory, immunological, malignant, whatever. This is a very big list. This is a very simple X-ray. I think there is no diagnosis except middle loop consolidation, mostly pneumonia. I think there is no other diagnosis. But if you compare it with this exposure, this is different, because you can notice in this X-ray that it's true that we have consolidation, dump consolidation, homogeneous and everything, but there are signs of atelectasis, crowding of the ribs, and elevation of the left hemidiaphragm. So mostly this is consolidation atelectasis. Is it pneumonia on top of malignancy, or it is actually pneumococcal pneumonia and simply associated with obstruction of the bronchus by mucus? This or that are possible. I think for this case I will proceed to do a CT chest. Multilobar pneumonia, no other possibility. You can read this X-ray in so many ways, so many differential diagnoses, but this is actually a typical pneumonia, Legionella pneumonia, Klebsiella pneumonia. This will cause a debate, is it TB or not, because I think we have a shadow in the subclavicular area with seemingly to have cavitation. Is it TB? Is it Klebsiella? It's Klebsiella pneumonia. This is a classical picture of severe overwhelming pneumonia of viral etiology. So even the X-ray will cause a lot of debate. The last point and the most debatable point is the utilization of bacteriology. And even without slides, it's a well-known fact that if you do a bacteriological assessment for pneumonia, this will be very good, because you will give your treatment on solid grounds. You will give it in a focused way. You are using the proper antibiotic. This is a fact. But the debate is about the use of bacteriological assessment. Are you going to do this for every case or not? We think that in simple CAP, by clinical and radiological patterns and your experience, you can just assume or suggest the causative organism. And based on this, you are giving the proper antibiotic. And nowadays, we are in the era of quinolones, and macrolides that will cover typical and atypical pathogens. So this, in part, solved this problem, which is a selection of the proper antibiotic unless there is a strict contraindication. So in simple CAP, uncomplicated case, no bacteriology is needed. But if the case after 3 to 4 days started to complicate, deterioration or no response, you can get a sample, and even sampling will be debatable. Is it simple expectoration? Is it induction of sputum? Is it probal? Is it what other means? Are you able to escape and bypass contamination of your sample by the upper respiratory tract secretions from larynx and throat, tongue and teeth? This is also debatable. But if you come to have no discussion, in nosocomial pneumonia, culture by bronchoscopy is essential, because in this very bad quality of patient, you have a lot of possibilities, a lot of organisms, from the opportunistic organisms, bacteria, viruses, atypical, fungus, protozoal, anything. So you have to do a culture for these cases. General guidelines recommend that gram stain is a good and palatable way for suggestion of the organism, because it will make a lot of difference if you say that this is gram positive or gram negative organism. But culture should be done only in the situations I just have described. This is in brief the points of bacteriology. So blood culture, sometimes we neglect the blood culture, but severe cases or cases who have been hospitalized, or patients who got pneumonia for the second or third time in a short duration, few months, blood culture is very essential. The only problem with blood culture is that there will be delay in obtaining the result. But you take the culture and subculture, and then you give the antibiotic just waiting for the result, and it has been found that the consumption of blood culture will improve diagnosis and consequently treatment. So as we can see, that pneumonia and its diagnosis seems to be simple, but there are many challenges and many debates. Please don't consider that every case presented by fever and infected simply as pneumonia. Be sure by all means that this is pneumonia, and diagnosis is not always straightforward. Clinical picture is not always classical, sometimes presented with general and extrapulmonary manifestations that will overshadow the thoracic manifestations. An X-ray is mandatory, and assessment of severity is multifactorial, depending on the clinical judgment, X-ray, hemodynamic, and hematological and metabolic factors. And finally, diagnosis of pneumonia is spoken of as a state of the art, with a lot of debates and challenges. Suspicion is the starting point, just suspect. And confirmation is the second step. It might not be easy. Different diagnostic modalities should be consumed to dissect away pneumonia from other mimics, other conditions. This is mandatory to avoid both under or over diagnosis, and so under or over treatment of such cases. And thank you very much.
شكرا للاستاذ الدكتور حاتم الدواني رئيس الاقتصاد بجامعه اسكندريه على القائمه السهل والممتنع، والموضوع كان في قيمه المؤتمر مع استقبال المؤتمر هو كنت جالس في الاستشارات الاستاذ الدكتور حاتم يتناول معنا هذه المواضيع والديبيت، وكنت جالس في الموضوع ده. الان حبيت ان انا اقدم خاتمه هذه الجلسه من ناحيه المحاضرات الدكتورة نبيل عبد الفتاح عين شمس. الدكتورة نبيل أنا عارف إنك أنت أستاذ مساعد على وش المساعد، على وش المساعد إن شاء الله يكون جامعة الأصول كلها يعني وشها حلو برضه عليك كده، ونسمع قريبا من كيف أستاذ مساعد. الدكتورة نبيل هتكلمنا عن أنتيبيوتيك الأكيد والقايد إنديكيتد هرمون.
First, I would like to thank Professor Tariq Mahfouz for inviting me to this conference, and I'm very proud to be in the same session with Professor Adil Khattab and Professor Hakim Al-Mallawani, dear professors and colleagues. First, acute bronchitis as defined by the American College of Chest Physicians in 2006 is an acute respiratory infection with normal chest x-ray, and it manifests usually with cough that might be associated with phlegm production, and it will last for almost about 3 weeks. 90% of the causes of acute bronchitis is usually viral in origin, commonly the respiratory syncytial virus, the influenza, the parainfluenza, and adenovirus. Very rarely it is caused by bacterial pathogen, commonly the Bordetella pertussis, sometimes also due to exposure to pollutants and irritants, especially cigarettes. Patients with acute bronchitis usually suffer from mild headaches, generalized body aches, fatigue, low-grade fever, usually cough, which is at first dry, then it becomes productive, chest pain, whether pleuritic or not, and also you might, on auscultation, find or detect diffuse bronchi and crackles. The diagnosis of acute bronchitis is essentially a clinical one, but you need to rule out the differential diagnosis of pneumonia, acute pneumonia, and Professor Hatem, he went thoroughly on this subject in the previous lecture or presentation, but all I want to stress is at least we should perform a chest radiograph in patients suffering from acute bronchitis to exclude acute pneumonia, as well as we should warn the patient or instruct the patient about certain criteria when to contact or when to seek medical advice. As an example, if the acute bronchitis symptoms last for more than 2 weeks, or if the patient started to develop hemoptysis, or if also the fever persisted when it was more than 38.8 degrees. The main issue of this presentation is the treatment, and the treatment of acute bronchitis include two main entities. The first is directed toward the supportive or the symptomatic treatment, and usually the physician should encourage the patient to be well hydrated, and this has like the benefit of liquefying the secretion and decreasing the fever. Also, he should be encouraged to be ambulant and to walk, and that still, and to take part of the chest physiotherapy. This will lead to mobilization of the secretion. Also, we should warn them and instruct them not to overuse the over-the-counter medication such as the antihistaminics and the pseudophenoephedrine. As for the antibiotic prescription or the oral medication, some of the physicians really prescribes bronchodilators to alleviate the symptoms, the rales and the wheezes. But as regards the antibiotic, first I would like to say or highlight that antibiotics does not cure viral infection, and it will not prevent other contacts to catch the disease, and it will not help you feel better if you take it. Most of the studies and the reports say that 60 to 70% of patients with acute bronchitis, when they seek medical treatment, the physician prescribes for them antibiotics. That is why, therefore, consequently, the Centers for Disease Control and Prevention, in collaboration with the American College of Chest Physicians, they started and they initiated a vast campaign, which is the Get Smart campaign, in October 2009 to address the physician, to make them aware and to dissuade them from the practice of prescribing unindicated antibiotics in acute bronchitis. And they stated that the only indication to prescribe antibiotics is the infection with Bordetella pertussis. As well as several meta-analyses of randomized controlled trials published in the British Medical Journal and the Chest Journal, they concluded in 2006 that antibiotics should not be justified in the treatment of acute bronchitis. Also, in the 2009 updated Cochrane review, the author enrolled 14 trials, or analyzed 14 trials involving over 1,500 patients. These trials included smokers, and they followed up the patient with acute bronchitis who received antibiotics, and the main result was that yes, antibiotics may have a modest benefit in the reduction in the days of illness, in the reduction in days of limited activity. These patients are less likely to have night cough, but they still exhibited abnormal spirometric studies, and the reduction in the mean duration of cough and mean duration of productive cough did not reach a statistical significant difference. Therefore, the author concluded that although antibiotics appear to have a modest beneficial effect, the magnitude of this benefit needs to be considered in the context of its potential side effects. Also, the data that is there for the patient who may benefit from the treatment is lacking. And the thing that I need to really emphasize that prescribing antibiotic for self-limiting condition is an economic burden, and it will only increase the emergence of resistant strains. Also, among the CDC campaign, they issued tips for the physician, they addressed the physician, and they issued tips to reduce antibiotic use. So they instructed the physician and they told them that they should tell the patient that and explain to them how that antibiotic prescription will increase the resistance. They should identify and validate patient concern. They should recommend specific symptomatic therapy. They should spend more time answering questions and offering a meticulous plan if the symptoms of the patient worsen. They should provide patient education material on antibiotic resistance, and they should remember that effective communication is more important than an antibiotic for patient satisfaction. Also, prevention of acute bronchitis is easily done, or could be easily done, through the hand hygiene, the hand wash, and making plan for the immunization required according to the patient's age and condition. Avoid pollutants and quit cigarette smoking if you're a smoker. At last, over the last two slides, I would like to display the Mayo Clinic opinion about using antibiotics in acute bronchitis, that antibiotics should be used wisely, and the CDC statement is whether you snort, you sniffle, or you sneeze, no antibiotic please. Thank you. Okay.